Thank you for coming to today's program. My name is Time Smiley, and I'm an administrative assistant at the JES. It's my pleasure to kick off today's event, and I'm here to do three things. One, just go over some housekeeping. Two, tell you about upcoming events. And three, introduce today's presenter. So, first, some housekeeping. If you need assistance during the event, please find one of our volunteers who will be happy to help you. Secondly, for our Q&A portion, please raise your hand to be called on and wait for one of our volunteers to come with a microphone before you ask your question. And please keep your questions brief and concise. Just remember to ask questions and not offer stories. And for our upcoming events, tomorrow, Friday, February 28th at 12 p.m., Karen Beowith, MPA, will be here at JES to present the Erie Community Foundation celebrating 90 years of investment and impact. Then on Monday, March 3rd at 6 p.m., Paris Baker, PhD, will deliver a lecture at Lincoln Community Center Library titled Cognitive Conception When Men Become Fathers. And lastly, as tonight's program is in partnership with LECOM Health, I would like to introduce you to our presenter, Carleen Cho, MD. She is a board-certified vascular surgeon who earned her medical degree from Drexel University College of Medicine. She completed her general surgery training and vascular surgery fellowship at Cooper University Hospital. She played a key role in expanding vascular surgery practice at St. Vincent Hospital, specializing in peripheral artery disease, limb salvage, aneurysm, dialysis access, and venous disease. She is also dedicated to medical education, mentoring students and vascular surgery residents. Please give Carleen Cho a warm JES welcome.
Hi, thank you for coming. It's a privilege and honor to be here. I feel like I'm too short. I can't even see over the monitor here. I'll stand over here. So today we'll just be talking about common vascular problems and treatments available. It's fairly informal. Just, if you have any questions or anything like that, you can interrupt me and flag me down. But essentially, the circulatory system is very vast. We've got arteries and veins, as you can see in this picture. I don't know if I have a pointer. Yes. So you can see, it makes up, it affects everything. It affects the brain, the heart, your extremities, all your organ systems, your kidneys, your lower extremities. So it's, we could talk for hours and hours and hours on vascular issues, but we'll only focus today on peripheral artery disease, carotid stenosis, abdominal aortic aneurysms, and venous disease. And hopefully you'll get a little overview of a little bit of everything that I do, okay? So essentially for arterial disease, one of the biggest culprits, I guess, is atherosclerosis. So essentially you have atherosclerotic buildup, and then what happens is because of all that plaque that you develop in here, then you end up limiting the amount of blood flow. So two things can happen. One, like the plaque can rupture, or it could be completely blocked, and that could, if it happens in the heart, then you end up getting a heart attack. If it ends up in the legs, you get decreased blood flow to the legs, et cetera, et cetera. So it affects, and like we said before, because it affects everything in your body, if you have atherosclerosis in your legs, you're going to have it in your heart, could have it in your brain. So every time we look at this, it kind of involves, all the different organ systems. So we always have to keep that in mind. When you look at the overlap, I think that in Europe they did the study and when they looked at all the overlap, and it's between having stroke incidents, heart attacks, and any peripheral vascular disease, all of those are all tied in together. So the major risk factors for development of atherosclerosis and ultimately for any limb issues, the major risk factors are smoking, diabetes, so 3 times risk factor. Smoking is a 3 times risk factor. Diabetes is 4 times. Hyperlipidemia or high cholesterol is a 2-time risk factor. Unfortunately, age, something that we can't change or stop or slow down. And then here we'll talk about this a little bit more. It's just more of this is like your ABI or kind of concomitant known peripheral vascular disease, or known or unknown, I guess, but we find out through this, but we'll talk about this a little bit later. But obviously, most of these can be modified. So, I think even though I'm a surgeon, the main thing for vascular is actually prevention, okay? And so, there are a lot of things that we can do to prevent this. Especially with smoking is, the number one thing that we could definitely prevent is just smoking cessation, or, starting young and just telling people don't start, because once you start, it's difficult to stop. So lower extremity PAD, this is like a huge part of my life. There can be multiple, there's no gradation, there's no way to predict who's going to develop it, who isn't, who's going to do worse, who's going to do better. And unfortunately, a lot of times it's not even diagnosed until it's too late. And so a lot of people won't even have symptoms at all because it's just such a chronic process. And because if you remember in that picture, you just got vasculature everywhere. So you have all these collaterals. And so once you start kind of blocking off one artery, your body's just trying to flood the other, get better flow where it needs to be. So it starts building what we call these collaterals and build to get them bigger and better and stronger. So sometimes your body's so good at compensating for this that you don't even know you have it. And so sometimes a lot of people who have PAD are completely asymptomatic. But once they do develop symptoms, then you could be put into two separate categories, okay? So the first one is claudication. So that's usually pain with ambulation. You can it's usually when you start walking, you either get tired and then your legs feel tired. Usually the classic thing is I walk a little bit, Charlie horsing or cramping in the calves. And then once you stop, then after that the pain kind of gets a little bit better and then you can walk again. So that's the classic presentation. So most people complain they get tired easily, they get horrible leg cramps and it's difficult, or they got to lean on something, or they just can't walk far anymore. So those are all symptoms of claudication. So when you have claudication, it means you have a blockage somewhere in your artery that limits the amount of blood flow that goes to your legs, okay? So when you're sitting normally, I could probably even feel your pulse sometimes, depending on where the blockage is. And then after that, once you start walking though, now your muscles are give me blood. And so all the blood is supposed to rush towards your muscles, but because of the blockage, the blood can't get there quick enough. And so that's when you start getting that crampy, painful feeling, or, just with the constant walking, then, it's either crampy or tired or heaviness or something like that. And so that's how it presents. In the claudication, because you only get pain when it's in a stressed situation, your legs are not in any danger of you're not in danger of losing your leg at that moment in time, okay? It's just it's mainly a quality of life issue. You can't go far, you can't do what you want to do. So that's in its category of its own. Usually, we'll talk about the treatment for that, but that's one spectrum of the treatment that we look at. The other spectrum is chronic limb ischemia. And when you're in chronic limb ischemia, that's when things get pretty complex, okay? So the main symptoms for that is rest pain, which is when laying down, usually the classic symptom is going to bed, you get excruciating pain in the foot or in the leg that just won't go away, keeps you up at night, or prevents you from going to sleep, or wakes you up in the middle of the night. And the only thing that'll feel better is if you dangle your leg over the bed like that. The reason for that is because when your arteries are so plugged, you're not getting any blood flow to the foot, or very limited blood flow to the foot. And the only reason why it feels better when you dangle it is now you're relying on when you dangle it against gravity, now your blood is kind of pooling in your foot before your veins can squeeze it all back to your heart. So you're relying on your venous system, the tiny little baby capillaries and all that blood pooling to give that little extra bit of oxygen for your foot to feel a little bit better. And so at that point, it's now, when people have rest pain, that means that your foot is in danger. Something must be done at this point because you're just not getting enough blood flow to the foot. And then the last one is, another symptom is obviously tissue loss. So any wounds. I'm sure you probably know someone who's had a wound to the toe, or when it gets all black, or or it gets infected. those are mainly, that's when, you need a good, like team approach where you have your heart doctor. So I think Dr. Becker had spoken 2 weeks ago. He's apparently on YouTube now, so you can watch his videos on YouTube. I work heavily with cardiology, and then you're going to hear from Dr. Colonna in a couple weeks, the foot doctor. And we work really, really well. We have to work together on when it comes to tissue loss, because now it's just like, can we save the foot? What do we need to do to save the foot? Let's make sure that, we've got adequate vasculature so the foot can heal, and then we kind of make all of our decisions concomitantly through that, or like, with wound care center, with, podiatry. So this becomes like more of a team approach with chronic limb ischemia, because things do get complicated, because if, like I said, once you're at that stage, it's kind of like, I like to like equate it to like you have like end stage vascular disease, right? Because things are not great everywhere in your body for you to develop these symptoms, because like I said, your body is really great at compensating, and this is kind of like, we can't compensate anymore, like we're done. And so now is the time to act. So the main way that we can, the very, very first stage for diagnosis is an ABI. Very busy slide, but what an ABI is it's very simple. You take a blood pressure in your arms, and then you take a blood pressure in your legs. And then after that, so the theory is, the amount of blood going to your arms should equate to the amount of blood going to your legs. And so if you have less blood going to your legs, it means somewhere from your heart down to your legs, there's a blockage somewhere in this region that's preventing you from having the same amount of flow here compared to here. So that's kind of like the theory. And so we make a ratio of it, or like a percentage from here that compares how much blood you're getting compared to your arm. So anything that we say is, anything between 0.8 to 1.4 is fairly normal. There's not really much. Normally, nobody has any symptoms at this point. Now, when it's like, when you're at 0.5 to 0.8, so you're only getting 50% here compared to here to 0.8%, then, something's going on. We probably should discuss it. So normally, the PCPs usually refer patients to me at this point. And usually patients present at this point, like, they start developing some claudication symptoms and like tiredness or something like that. And then less than 0.5 is severe arterial disease. And at this point, there's really significant claudication, or people are starting to get rest pain or wounds that we need to address. Now, in the 1.4, anything above 1.4 is, it means like, so sometimes someone will have like, the blood pressure here is like in the 120s, and then suddenly here it's like the blood pressure is like 200 or 180. So it's like, how are you getting more blood to your legs compared to your arms? And that's actually not the case. It's just that when we take a blood pressure, the blood pressure cuff collapses your arteries to see how much pressure it takes to kind of collapse that artery, and that'll tell you how much pressure is going through your blood vessels. So when you have vessels that look like this, where it's all just calcium laden, it's like a rock or like a pipe. So when you're trying to collapse that vessel, it's just so hard that it's like, we call it non-compressible, like you just can't collapse it. So the numbers are artificially high. So even sometimes like you'll see like, oh, they might be at 0.5 or 0.6, but because it's so hard, like the numbers come artificially high, and you're like, and it'll be like 1, you're like, oh, it's normal, but it's not. It's just falsely elevated. So we have to, when we see these ABIs, we kind of take it all into consideration and make sure that the clinical symptoms and and we look at the symptoms, the clinical exam, and this all together, so that we know we can kind of make a decision to move forward. Of note, I should also say that, like I said before, with the ABIs, we saw the risk factors of like, if you have the ABI, it increases it is a risk factor for developing chronic limb ischemia. And so now there's a big push to, have people who are at high risk. If you have high blood pressure, if you're, a little older, if you're, a big smoker, something like that, that people should just get regular screening, because you can be asymptomatic, so you don't even know you have it, and get screened so that that can kind of direct better treatment and prevention, or at least addressing some risk factors that, we could do better to, improve your health. So the treatment, like I said, medical prevention first and foremost. So that's limiting risk factors, right? So not smoking, stop smoking, that's like number one. I can't stress that enough, but stopping smoking, that's like the first risk factor. That's the not easiest, but one that we can actually do. Glucose control, so the diabetes is a huge, huge risk factor. And smoking and diabetes together is probably the absolute worst when it comes to critical limb ischemia, or when you're, people at risk for wounds in the foot. Because with diabetes, your vessels are already affected from the diabetes, and then you add smoking on top of it. It's like, it's like adding fuel to the fire of just really, really injuring those blood vessels. So smoking and diabetes are probably the worst combination one could ever have. Statin therapy, so one of the risk factors you saw on the previous slide was cholesterol. So statin therapy is important in two aspects. One is obviously it brings down your cholesterol levels, so that'll help with your risk factors. But the second is also what it does. So I like to have people on statins, whether or not you have high cholesterol or not. And there are studies that show that people who are on statins and people who are not, who have the exact same level, same cholesterol level, the ones on statins actually have a less risk of heart attack and stroke. And the reason for that is this. With statins, you have all this plaque. So this is your blood vessel. This is what we call the lumen, or how much blood is actually flowing through here. You have all this gunk, just like sometimes it's just like this mushy, it's the plaque that you have. Sometimes it could be hardened like calcium, that's usually hanging around in this area. Or it could be just like this mushy stuff that just kind of like squeezes like jelly, essentially. And that's just consistent of just like a bunch of like fat molecules, some your white blood cells and stuff like that. So you have this little plaque that kind of keeps everything in place. But for when you take statins, it actually like stabilizes. It makes you have a thicker cap here, so that what happens is, like, especially for heart attacks, you imagine a very small vessel, you have all this gunk just explode through, it can pop through right through this cap, because this cap's pretty thin. Once it pops through this cap, then it kind of could either clog this entire hole, or it could kind of spread and clog the artery further down. And so that's essentially what causes the heart attack or stroke. So that's why with the statins, I firmly promote it, just because it kind of thickens this layer so that this plaque rupture is less likely to occur. So statin therapy is a very important. Antiplatelet therapy, same thing. Aspirin therapy, usually it's either aspirin or Plavix. Taking one of those for high-risk patients is also, a good preventative. Prevents your platelets from clotting together, developing a clot. When you have really small, like a really small lumen or a small area, if you have constant just blood flow, like your blood is nice and thick, and so with constant inflammation, everything like that, there's a possibility of clotting it. And so this kind of prevents that from happening. And then when it comes to claudication, the best thing for claudication is a walking program, okay? So there's kind of the supervised and like the community program, right? So the studies that they've shown is that when people have issues with claudication, like let's say you're like, I can walk 50 feet and then massive pain. So when you do a 30-minute walk, it's essentially you're supposed to do 30 to 45 minutes of walking 4 days a week. And there are some places with like physical therapy that they supervise you and make sure that you're on it, that you're not kind of like, on the treadmill and you're like walking at 0.5 miles, like nice and slow and slacking off. Like they make sure that you show up, you do the walk, and then after that, and then you do your stretches or whatnot, and then you go home. So that's like the supervised program. So they looked at all the patients who suffered from claudication, and they did this walking program, and within 6 weeks, everyone was walking at least double the distance that they could before. So when they went from 50 feet, now they're at 100 feet, okay? And the reason for that is twofold. One is that when you're walking like that, and your blood, your muscles, they demand a lot of oxygen, and so when you do this walking program, it increases the size of your collaterals and makes you dump all that blood a little bit more efficiently to where it needs to go. But also, your muscles also learn to not have to require so much oxygen and so much blood. So it's kind of a twofold thing, and that's why people are able to increase their distance after walking for so long. There's also some community programs. I don't know that we have any, but it's just essentially like a bunch of people who have claudication problems. They all meet up one day and just 3 days a week, and they're like, let's meet at the mall. We'll walk our 45 minutes and then get out. And that way you have some people to work with. People are holding you accountable to show up, and it makes it a lot more fun, right? Because you can chat and catch up and maybe even shop, So there's the community walking program as well, and doing both has shown to increase your walking distance and before you get that pain. And so by doing all this could theoretically fix your claudication symptoms to the point where it's not going to be completely, you're not going to go run a marathon in the next year, but at least it'll get you to where you need to be, where you're just like, I can do my daily activities, I can go shopping, I can play with my grandkids and chase them without having to stop because of the pain. And so sometimes that's all it takes, but other times, it's not enough. So that's when we start talking about surgery. So there's multiple things that we can do in surgery. The first one is the angiogram. So there's two things that we can do depending on what we see at the time of surgery. So the first one is what we call like an angioplasty or ballooning. And essentially, if we take a picture and if we see like a bunch of narrowing or anything like that, you'll see like this is an example of a blood vessel, what we see under x-ray. So we inject dye. This is the same one if you've ever had like a CT with contrast. It's the same thing. It's just this dye that helps you watch the blood flow down. And everything is 2D, but we see the blood flow here, and then all of a sudden it stops here. So for this one, though, you would see blood flow here. You see like almost like a little hourglass shape, and then after that, like back to normal. So if that's the case, we usually balloon it, and then we just essentially just flatten the plaque against the walls, and then we take another picture. If it looks gorgeous, we walk away, and that's called an angioplasty. There's a couple of different balloons that we can use. There's a regular, we call a POBA, or plain old balloon angioplasty, which is just a regular balloon. And then they have drug-eluting balloons that have drug within the balloon, and so when you balloon it and you smush it against the walls, that drug kind of smushes and like infuses into your vessel. So we leave it for like 2 to 3 minutes, depending on the company, and that drug just kind of sits there. And by doing that, the drug prevents you from this happening. Like what happens normally is when you manipulate it, you get a little bit of scarring in this area because, you just manipulated the vessel. So now your body's attacking whatever. It's like, we just got hurt, So the body just attacks in that area, and then you end up getting a little bit of scarring. So the drug-eluting balloons kind of prevent that scarring process and, kind of decreases your risk of recurrence. Or if that doesn't work, so like let's say we balloon this and we take another picture and it still looks like this. So at that point, then we say, all right, then we probably should stent this to give it a little bit more oomph to it. So we usually pass up a stent. Depending on where we are in the body, will kind of determine what kind of stent we use. But after that, we just deploy the stent, and it kind of pushes everything up against the wall, and now the flow is nice and open. Again, there's multiple different stents that are available. There are drug-eluting stents as well. And that also, same thing, it prevents the recurrence of a blockage because, like I said, your body likes to scar. Whenever it's manipulated or anything like that, your body tends to scar, like, usually right over here where the stent kind of sticks to where the stent and the artery meet at the very ends, because the blood flows here, swishes here, and then, you get that because of that little step off, you can have a little bit of scarring. So the most common places where things kind of recur is usually at the edges of the stents. So you can balloon or stent. And so this is a perfect example of someone who is stented. So you have the flow goes here, and all of a sudden see that it stops here. So there's a big old blockage there. They were able to get through and across, and then after that, you just put a little stent across, and suddenly you got blood flow all through there again, reestablished. So if we can get away with that, usually there's a lot of studies that say, like which one's better. And honestly, at the end of the day, it's all patient-centered, right? There's no right, like just single answer for one, like for the entire, there's no one-size-fits-all kind of thing, right? So we usually, when we look at the approaches, like if it's someone who's very young and very active, and they've got like horrible long blockage or something like that, then we start thinking, you know what, maybe we should do a bypass because it lasts a little bit longer. If it's someone who's pretty old, is not really walking that much, and we're just trying to, kind of stem them to help them out a little bit so they feel a little bit better, then we start thinking stents, and that goes anywhere in the leg. So right now, like, the hot topic is like, what do we do for all the all the arteries down here, what is the right answer for in terms of like bypass versus stent. And like I said, at the end of the day, I think it's a good conversation between, you know, the physician and the patient, and kind of looking at the overall picture. There's no right answer, and that's something that, you know, we like to discuss at the time of surgery or procedure. But yeah, so if an angiogram, like let's say we try opening this, won't, it's just blocked. So then after that, now we got to talk about bypass. So essentially what a bypass is you have your blood flow here, like let's say you have a blockage here. It's actually very similar to that picture we just saw. Then we say, you know, we essentially bypass. We go from here all the way down to here, and we bypass the blockage. So obviously this is open surgery. It's a little bit more complex than, you know, than doing an angiogram. And so, you know, usually the surgery is about, usually the surgery you go to the hospital for, you stay in the hospital for a little bit, and then after that we follow. For both of them, we require significant follow-up though, constant follow-up. So the graft you can use, there's a variety of grafts we can use. Obviously the vein is the best. Well, I guess I should rephrase that. Depending on what you're bypassing to, vein is usually best, okay? Because vein lasts a little bit longer. It's part of your body, so it's like less likely to get infected. But there's also graft, which is like it's a PTFE graft essentially. So it's like, you know, the same thing that you have for like the jackets and backpacks and all that same material that we essentially sew from here to here, and the blood flow, and then that way the blood flow can go through. Graft, you know, it has a higher chance of infection because it's not part of your body, so, and it doesn't last as long because it's just not as compliant as your own vein, and so we tend to like to use vein more. Now the exception to that is obviously like over here. So if you're in the if we're going from a bypass from above the knee to the groin, we tend to choose graft, and the reason for that is they did comparison studies of people who used vein and people who used graft, and they had the same durability, they lasted the same amount of time, and so at that point we prefer to use graft up top here to prevent, to kind of save that vein so that, you know, if God forbid that graft fails, you have the vein still left over to bypass a little bit lower, okay? It should be, it's like of note though, anything that we do, unfortunately, with vascular surgery is, like I said, it's kind of like a end stage or chronic process, right? So it never ends. So anytime we do these manipulations and whatnot, it's kind of like slapping a Band-Aid and like trying to like we're fixing the symptom, but we're not fixing the problem, okay? And so unfortunately, with all of these things that we do, that's like our main focus is like, what are we gonna do? Like it's like we're always facing recurrence, right? We're always trying to, or like relapse, I guess. So we always have to be very cognizant of every procedure that we do. And so that's kind of a big factor into how we treat patients and what we like kind of we always have to think about the next step, or like what options do we have next. So then after that, this new device came out, and I want to say early last year. So we were actually the first in the region to use this. So this is the P-tab, and it's almost like a hybrid approach of both your angiogram and your bypass, open bypass. Okay, so this is a phenomenal device that it's essentially an internal bypass, if you may. So what it is this is all done through just wires and catheters. So it's like an angiogram. And so if you have a blockage here, what we do is we access the artery here, we go up and over, and then after that we go through the artery, and then after that we poke into your vein that's sitting, because your arteries and veins lay right next to each other. And so after that we poke through the vein, and then we come back after your blockage, we come back and poke right back into your artery again. And so now you have a bypass that's going, and then after that, once we get through all that, then we stent the entire way over. So now you have essentially like a bypass graft that is going through past here without requiring any open surgery. And so this is kind of like a whole new world in terms of like a hybrid, like almost like a hybrid approach, or a hybrid of the two, because you kind of get the best of both worlds, because now you could treat this big blockage that you couldn't before by bypassing it this way. you decrease the risk of infection because you're not using a piece of plastic tubing. You don't have to stay in the hospital for, I usually keep patients overnight just to observe, make sure nothing crazy is going on. But this, usually with the bypass, you got to stay for 3 nights and you have all these incisions to recover from. By this, you just have like a little puncture in your groin, a little puncture in your ankle, and that's it. And that's all you have to recover from. So this is kind of like the new, like greatest, not greatest, but like biggest advancement in terms for peripheral vascular disease that we have. And so I'm pretty excited about this one. But again, it has to be with the right patient, with the right anatomy and everything like that. The durability, so far the studies have shown that the durability of it, or how long it lasts and stays open, is about equivalent to doing an open surgery. Before I go on, any questions about peripheral vascular disease? Yes.
I just want to make sure I understand that section where you're going into the vein as well. I want to make sure I understand, in that area where the artery and the vein, you're kind of sharing it. So you have blood going 2 ways. So how does the blood flow work inside that section? Is it literally trying to go in 2 currents each direction, or?
So what happens is the blood flow goes, so this stent is all covered. So there's like a cloth that covers it. And so the blood flow only goes through here, and then while it shares the vein, the blood flow only goes within this artery. But because it's like waterproof, so there's no crossing of blood within the stent.
So it's like sharing it 50-50.
It's sharing
like half of it's
space.
dedicated to going one direction for a short period, and then the other half is going the other direction
it's
for
sharing
that
this
short period.
It's sharing, so it's sharing the space within the vein, but this is only going in one direction, and then your vein, you just have regular flow. So this area, your vein's a little bit more blocked, so like your vein has to be a certain size in order for us to do this surgery. But it's only going one way. It can only go one way, and because the artery, like the pressure is so high anyway, like there's no mixing or anything like that.
Okay.
And then after that, but you are sharing space, yeah.
So can you tell me what PTAB stands for?
Oh, it's like percutaneous, I think, I already forgot, it's like percutaneous trans angio, like a bypass or something like that, yeah. Yeah, but we just go by the detour, yeah.
Thank you. Is it true that enough plaque could build up on the inner walls of the artery that it would prevent, say, a scanner to see that indeed there was a blockage in there? Or will the scan go right through that plaque that's built up on the wall? Or does it indicate a thickness of the plaque so you can, without question, know that there's a blockage?
In terms of within it for an ultrasound, or what do you mean scan?
Yeah.
Yeah, so for ultrasounds, it's a little bit difficult. So ultrasounds, we rely on a couple things. When we look at this flow and the speed of blood going through it, so if there's no blood going through it, you pretty much know, it's 0, right? But anything between, a blockage of, we'll say 0 to 99%, it's a little bit difficult to tell. So we actually have to base things off of how fast the blood is flowing, and you compare it to the segment above it. And so if it doubles, so if it's going 100 centimeters per second, and then suddenly you look a little bit lower and now it's going 200 centimeters per second, then you know that there's a blockage in between the two that now that it's kind of doubling, and so that's usually about a 50% blockage. Yeah. But again, ultrasound's not perfect, CT scan's not perfect. So in terms of how we pick and looking at blockages, we always start with an ultrasound, right? Because one, it's non-invasive, it's the easiest to look at, and it's a little bit tech dependent, but you can actually get a good idea off of that. Now, obviously, you're not, you gotta they kind of scan your artery at the same time, but you're not gonna pick up every single blockage, and so sometimes the blockage can get missed. And so at that point, then, there's always the CT scan where, you get the IV contrast, and the contrast shows how your blood is flowing. The limitations of a CT scan is, one, it's a little bit more invasive, right? Now you're getting radiation, you're gonna have to get an IV, you get contrast, and contrast isn't great for your kidneys. And so if you don't have good kidneys to begin with, then we're more worried about kidney injury from the contrast. And then when you're, especially for the vessels below the knee, you have three vessels, three arteries that go below the knee, and those vessels, with diabetes, you have kind of what I showed you before, like if you have like all that thick calcium, those thick pipes, it's difficult to see because the contrast is white, and then those arteries are also white. So it's like, and the arteries are really, really tiny. So it's like, is that contrast or is that the artery? It's difficult to see like the minutia of the blockages at the level of the tibias or at the level of the calf. So at that point, then we start talking about doing an angiogram if we're really convinced or if we're concerned that there is some type of blockage, then we kind of skip to the angiogram. Now the angiogram has its issues because now we're talking, it's a procedure. It's maximally invasive, right? Or it's more invasive, I should say, than it's more invasive than a CT scan because now we're doing a procedure, we're accessing the artery, but then at least you have like a decreased amount of blood flow. It's therapeutic and diagnostic, and you can actually get a better idea of what's going on specifically with the tibial vessels. So that's kind of like our what do you call it, like treatment diagnosis modality. Yep.
Can I ask that? What is an angiogram?
An angiogram? So an angiogram is essentially looking at it's a picture of your blood vessel. So essentially what we normally do is we access the blood vessel, we inject some contrast dye, that same one that you use for the CT scan, and you can see the flow of the blood to wherever you're looking at. So if we're looking at the legs, usually we cross up and over, depending on if someone's had like multiple surgeries in the past in the belly in terms of like if they had like an aneurysm repair or something like that, then we have to access somewhere else. But essentially we just inject some dye, we see how the flow, we see like kind of like how briskly that flow goes, where that flow goes, and you can actually see where the blockages are, because you're watching the blood flow essentially, because the contrast gets mixed into your blood, and so you can see the direction of flow, and from there you can determine, does someone need to be ballooned, does someone need to be stented, and it can just be all fixed right then and there. But it is a procedure. Yep.
On an angioplasty, what you said, you can put drugs into the balloon. What kind of drugs would you typically put in there?
It's usually like paclitaxel or like the same chemotherapy type drugs where it kind of slows down the scarring reaction. Yeah.
Do we have any more questions?
Okay. So next we'll move on to carotid disease, which is also, one kind of like peripheral disease because it is affected, once again, by atherosclerosis. So carotid disease is split into two different categories. You can have the symptomatic or the asymptomatic. So carotid disease, unlike your legs, it's not like, because I have less flow to my brain's going to hurt or it's not going to work as well or anything like that, all right? You don't get claudication of the brain, okay? But it's kind of, but if you do have a blockage, the concern is that, if you have all that mush and all that stuff growing in your arteries, it's the arteries that feed the brain. So the main symptoms that it has is either stroke or like an eye stroke, okay? The eye stroke is what we call amaurosis fugax, which essentially, it's almost the classic presentation is someone will be watching and then all of a sudden they'll feel like a dark black curtain just kind of comes down and over the vision, okay? And then after that, sometimes it goes away, sometimes it doesn't, and you're permanently blind. And essentially that's like you had a stroke in the eye. If it goes away, then it's like a temporary stroke of the eye. So these are the things that we always ask for in terms of symptoms for carotid. If someone has a stroke versus like someone that we accidentally or incidentally find with a blockage, we treat them both in different ways, okay? So for me, usually someone who I think is someone who's fairly high risk, like I said, high smoking history, whatnot, or smoking history with hypertension, hyperlipidemia, and they've already got vascular disease in their legs, I always like to check the neck because like I said, you don't really know you have an issue until you present. When you're symptomatic, it's like with a stroke, so it's already too late. We want to catch that, before that happens. So usually we use like an ultrasound to screen or to look at patients. So let me see so essentially, in terms of treatment, for asymptomatic patients or patients who are we just find out that they have like a blockage in their artery, we usually wait until patients are about 70 to 80% blocked before we talk about doing surgery. And the reason for that is surgery is not, it's got a lot of risks, right? And so it doesn't make sense if you were never going to get a stroke. There's no reason for us to accidentally cause a stroke doing surgery to prevent something that was never going to happen, right? So when you're at about 70 to 80% blocked, that's the time when you're at a higher risk of getting a stroke if we do nothing, okay? So asymptomatic, a lot of patients will be like, I don't understand, I have a blockage in my artery and you're not doing anything about it. Well, that's because it's not so high that we're worried that you're gonna get a stroke yet until you reach about 70 to 80%. So we kind of leave patients alone. Medical treatment, again, the statin therapy to make sure you don't get that plaque ruptured, and starting on aspirin, heart healthy diet, you treat all the diabetes, cholesterol, all of that. So that's in the asymptomatic range. Now, the symptomatic patients who are symptomatic or they present with a stroke or something like that, that becomes, not an emergency, but an more urgent procedure. And so normally they've done a lot of studies, like when is the right time to perform a carotid surgery in a patient who presents with a stroke. And the golden time is between 2 days after the stroke to 14 days. In that time is the best optimal time to perform surgery. And the reason for that is if you do it before 2 days, you're at a higher risk of having a worse stroke or bleeding complications or multiple things because your brain's already in haywire because you had that stroke. And so by doing it too soon, you're actually at a higher risk of having complications. And then 14 days later, if you don't do anything, there's a chance that within that time, you have a higher chance of having another stroke in that time. So that's why we try to operate between 2 and 14 days of a stroke when someone presents with a stroke. And again, that's if someone has an actual blockage. If someone presents with a stroke, but they have no blockage, we're not going to just willy-nilly, or even if they have a low amount, a 30% blockage, it's not something that we would do because that's clearly not the source of why the person had the stroke in the first place. And so normally we diagnose with ultrasound to get a good idea. The ultrasound is a little bit iffy, I guess. So the reason why how we got our numbers for ultrasound is, like I said, we look at the speed of how fast your blood is flowing, right? So when they did the studies, I think it was 10,000 patients, and they ultrasounded the patients, and then they did an actual angiogram and looked at the arteries to see how blocked it was to compare the numbers and the numbers is from the ultrasound and to compare it to the percentage of blockage for the angiogram. So when presented with a carotid ultrasound, you're going to see it's either going to be less than 50%, 50 to 69%, 70 to 99%, or 100% blocked, okay? Those are the numbers that you're gonna see because you can't see there's a 32% blockage because there's no way the ultrasound is that accurate, okay? So you're only gonna be in 3 separate categories or at 100% blocked. So normally we operate from 69% and really above for symptomatic strokes. The most beneficial those usually, we'll say 70% and above. That's the group that has the most benefit from getting surgery after having a stroke. Is anything above 70% for symptomatics. There's so another thing of note is if someone presents with a stroke, doing surgery is not going to make them better, okay? It's not going to take away the symptoms or anything. The only thing about carotid surgery is that we are preventing another stroke or a second bigger stroke, which is a little bit frustrating because it's yeah, but I can't move my face or something like that. You're not going to fix this, and it's unfortunately when you present with damage to it's brain damage. Unfortunately, that can't be reversed, and so. It's a little bit frustrating when we do carotid surgeries because I feel, it's how do you feel? It's I feel the same as before you did the surgery, but now I have a big old scar, So but again, it's all about prevention for a bigger second stroke. And when patients present with a first stroke, that's why we want to really intervene because it's this warning sign, especially, with the eye stroke, it's a warning sign that there could potentially be a bigger, badder thing that could happen fairly shortly. So that's why we try to operate within that time. So normally, like I said, we get an ultrasound, we try to, it stratifies and tells us what range you're at. Because if you're between the 0 to 50%, then we kind of just like, all right, that's not the source of your stroke, or there's nothing to do. Once you get to about the 70% and above, then we got to really look at it. And so we usually get a CTA of the neck, okay? So that's the CT scan, and they inject the dye. That way you can get an exact percentage of just how blocked it is. And because sometimes, the ultrasound, it's a little bit flawed, right? Because you're taking a Doppler, you're taking a probe, and you're putting it on the artery. It has to be looked at exactly 60% of the artery, but your artery's if your artery's curving all around, then you're not, where are you looking at this? It's not at a 60-degree angle. Maybe you're looking at it 100-degree angle or something like that. So it could be artificially high. So, someone might say, oh, you have a 99% or 85% blockage, or we'll just say between 70 and 99% blockage, and then we get the CT scan. It's like, no, it's perfectly fine. And so that's why we get the CT scan, to kind of eliminate that kind of error. But the screening is, because it's non-invasive, and it kind of gives us an idea of where to go. So the CT scan tells us how much it's blocked, and also like the anatomy, because the anatomy is very important, because it'll tell us, what kind of surgery you're going to be able to get from that. So essentially, when you look at it, the blockage is always, so this is your internal artery, the internal carotid, and this is the external carotid. So it sits right over here. So that branch, it could be way up here, or it could be like down here, okay? And this the external feeds the face, the internal feeds the brain. And so usually the open surgical has been for the longest time like the gold standard of how to fix these, how to fix it. And essentially it's called a carotid endarterectomy. And essentially we make an incision along the neck, and then after that you clamp the arteries, and then after that you open the artery up, and then you just clean out all that gunk there. And then after that, we put on what's called a patch. It's usually like a part cow heart, part plastic. It's like a biosynthetic patch, and you just sew it on and cover it up. And the reason for that is because if you just sew this back together after you're done, you go from you sew it together and it's kind of just mushed together, and so you're back to square one, because now you've got this tiny little artery. So that's why you got to put the patch to keep it nice and open. And so that's the carotid endarterectomy. And so now you get rid of all this junk here, and then after that, the flow goes straight to the brain. Obviously, the risks is stroke, so that's why I said we don't willy-nilly just, operate on anybody who has a slight blockage. We wanted to make sure that we're doing the right thing. If for any reason, though, patients had radiation in the neck, this branch is way up here, like closer to the ear or something like that, we can't reach that open surgically, or not easily, or, comfortably. So if that's the case, then we resort to stenting. For the longest time, there's always a war between cardiology and interventional radiology and vascular surgery, right? And so for the longest time, it's just like, a lot of times it's like a lot of interventionalists will stent from the access the femoral artery, go up to the carotid arteries, and then stent it, which is, I think, a great, for patients who are super high risk or something like that, who can't undergo general surgery or anything, or a general anesthesia. I think it's a great option, because if they're not anatomical, if the branch is too high or something like that, and they can't get open surgery, or they're too high risk, or they've had radiation, stenting from the groin artery is fantastic. You just bring them in. But it's fairly difficult, because if you think about it, you're going from the groin, you got to go up in the aorta, you got to go around the arch, then you got to go backwards into the right or the left. And so it's a very, there's a lot of, twists and turns. So it makes it a little bit difficult. And so, Dr. Becker does this phenomenally, and he's a master at it. So if I ever needed anyone to do a stent for that, I'd have him do it instead. But they came out with this device that kind of, prevents all this twisting and turning, right? Because the biggest risk of when you go access the groin and you go up into the arch into the arch of the aorta is that when you inject dye or any manipulation, it can actually cause a stroke, and it can go to either side, because you're down here and your arteries and the blood flow is going up. So you can actually get a stroke just from manipulation. So this is called it's the TCAR. And so what it does is, and this came out, I want to say maybe like 10 years ago. But essentially, you cut down on the artery here, and then you do what we call flow reversal. You connect it to your vein. So now when you clamp the artery, the blood flow is going through the sheath and then into your veins. So you're returning the blood into your veins. And then there's like a little filter here to prevent any garbage from the plaque to go into your bloodstream. This is important because anytime you manipulate the arteries, so like, and you can see, I guess you can see a little bit of that plaque. So if you imagine, if you put up a wire here, you got to traverse through all this plaque. You're mucking around in like this like hostile area, and there's always the concern that you muck around here, then you're going to send all the stuff straight up, and that goes straight to the brain. So then we're back at square one. We're trying to prevent a stroke, and we just cause a stroke, right? So by clamping the artery down here, now there's no blood flow going this way. So you're relying on your collateral. So if, like, let's say this is your left side, you're relying on your right side to bring the blood flow, go through your brain, and then it comes back down through your external this way. And so now blood flow is now going towards the direction of your sheath. And so then after that, so it goes towards the direction of your sheath and then down to your veins. So this will prevent any major risk of a stroke or, just from any manipulation at this point. So that's why, like, this was kind of huge in terms of stroke prevention or decreasing your risk of stroke when we perform these carotid surgeries. Otherwise, when we do it from the groin, you have to put a wire up. So you do have to muck around here. You put a filter here, and then after that you can balloon and stent and with a filter, and then after that you retrieve your filter. So all the stuff gets caught in your filter, but sometimes just trying to get your filter up there, that's like the highest, that's the time of the highest risk, because now you're traversing through this area. So this procedure limits that, and also limits having to go through like the arch, because your arch is here. I think they have it's a very faded thing there, but the arch is here, so you don't have to worry about going backwards and maneuvering through the entire arterial system to get to the neck. That's all about carotids. You guys have any questions about carotids? No? Okay. So, yep. Yeah.
You could probably hear me. Thank you. When I go to my annual wellness physical, and the doc, is running his stethoscope down through here, and I say, "What do you think, doc?" He says, "Oh, it sounds great." Now, listening to you and these percentages of blockage and so forth, I'm wondering, can he really effectively know whether or not there is a tendency to be clogged a little bit, or, you know what I mean? Is that effective to listen to blood flow?
Yeah, I mean, I think it depends on the physician, right? I mean, if they've been doing this, like they listen and then they get an ultrasound and they correlate it, like some physicians are phenomenal. For me, I wouldn't trust me, like I wouldn't trust me at all to listen for that. I'd be like, it sounds like it, or it could have been your breathing, because you're looking for a sound, which, when you're breathing or anything like that, it can be kind of inaccurate. So for me personally, I usually just get, if there's any doubt whatsoever, I usually just get an ultrasound, at least just one as a baseline, because at that point, then you know where you're at.
Yeah. It concerned me to a point where I see these ads, that here comes a traveling van into town for $169. You can get scanned from top to bottom, and and you can find out things ahead of time.
Right.
Rather than wait another year, for another physical. And
Right.
Is that?
Well, you hold on to that, because I have a little plug in a little bit. But yeah, so we'll talk about aneurysms. The next one is aneurysm. So this is less, while the same risk factors apply for for atherosclerosis, it is not an atherosclerotic specific issue, I guess I should say. So aneurysms are the ones that we normally treat is abdominal aortic aneurysm. So the blood flow, your blood goes here, it's from the heart down the arch to your kidney arteries, and usually it's in this segment that you can have so these are your kidney arteries, and this is a segment where you can have an aneurysm. And what it is essentially, it's like an outpouching of your arteries. Depending on how big it is will kind of determine our next step. But for aneurysms, again, smoking is the biggest risk. In fact, it has a 5.1 risk of developing our aortic aneurysms. Family history, age, coronary artery disease, cholesterol, these are all risks. COPD, which is usually part and parcel with smoking. So these are all risks for developing aneurysms. In fact, because smoking history is so big, Medicare actually came out with a ruling that says anyone above 65 years old gets one free ultrasound screening if they've smoked 200 cigarettes in their lifetime. So that's because it is that important. It's important to screen because, obviously if you've got an outpouching of the biggest artery in your entire body, there's always a concern that it can pop. 1 in 3 aneurysms will pop. They're usually asymptomatic. You don't know you have it until it's too late. So it's usually you don't know you have it until it's oh my God, my belly hurts and nothing I do can make it comfortable and it's spreading to my back or it's spreading to my groin. And so by then it's way too late. And so we like to capture people before they get to that stage because if it ruptures, it's fairly deadly. Only 50% of people actually make it from home to the hospital. And then after that, only 50% from those actually make it out of surgery because it's very deadly. So we try to catch it as much as we can. A UK study showed that after they started screening for all of these aneurysms, there's a 58% decrease in aneurysm deaths. And so, and that's why, with Medicare, we try to screen early for high-risk patients. Unfortunately for women, it's a little bit more difficult because women have smaller arteries, and so applying the same sizing for women is a little bit difficult compared to men because of when we define aneurysms as a doubling of increase in area. And so for a woman, if their aorta is 2 centimeters, the doubling would be 4 centimeters, right? But men usually have if men have a 3 centimeter aneurysm, doubling would put them at 6. So it's it's at 6, so you should fix it. But for women, it's if you have 4, should you fix it? Because that's not in our indications of surgery, right? So I think there's most of our all of our aneurysm data is based off of a veterans, the veteran database, which unfortunately is all, the majority are all men. So that we don't have a lot of good women data. And so now they're starting to get all of that just to see what is the right time for us to fix it. Because again, with surgery comes risk, right? And so if someone has a 2 centimeter or 3 centimeter aneurysm, is that worthwhile fixing? Probably not, because the chances of rupture is 0.3% a year, right? So it's you're gonna put them through some big surgery only for them to not ever rupture in the first place. So we usually monitor anyone who again is high risk. We usually monitor and see, we start screening them. And then once, we see the size, we start following them, and surveillance essentially. And we see, and then after that, when we get to about 5 centimeters, 5 to 5.5 centimeters, now your risk has jumped up from 0.5% to 1.5% to 1 to 11% per year. So at that point, you're at a much higher risk. So it's now we should fix it. So our indications for repair are usually, again, for men, it's usually anything from above 5.5 centimeters for males and then greater than 5 centimeters for females. And then or if there's a rapid growth. So if you come in and you're I have this aneurysm and it's 4.2 centimeters. And then 6 months later you come in and suddenly it's 5 centimeters. And it's we got to fix it because it's growing too quickly that it's going to be at a high risk of rupture. So that's why the surveillance is exceptionally important and screening is exceptionally important so that we can kind of capture it to know that we need to follow it. So next picture, not for the squeamish, but essentially this is how we repair the aneurysms. This is an open aneurysm, so this is the big surgery. There's multiple ways to approach it. You can either do a big incision through here or through the belly, and you kind of move the bowels behind. It all resides behind all of your bowels in in the retroperitoneal or behind your bowel space. So this is a massive aneurysm, as you can see, and this is the head that's up here, legs are down here. The aorta comes here, and you can see this is what it looks like in real life. And then these are the iliac arteries are fairly diseased. So this one they can't just do the standard. They got to fix this too, because these are huge. These arteries are huge too. So this part here is right there essentially. So this is the open repair. Essentially, you clamp up here, you usually clamp up here, and then you sew a tube graft over here. So now blood flow is going through here and then down to your legs. There's multiple, like, there's a lot of complex things that you need to think about when you do these repairs, because sometimes the aneurysm goes all the way up, to here, and then you got to, think about reimplanting renal arteries and this and that. But essentially, it's a fairly big surgery, right? So back then, when this was our only option, we really don't want to fix it until you're probably like 6 centimeters, like ready to rupture, because it's a big surgery. It's, it's difficult. There's complications. You got to clamp your entire blood flow. And so, like, when you unclamp, it's very straining for the heart. But a lot of times, this is our only option for, depending on the anatomy of the patient. So the open surgery, we can repair it that way. The benefits of open surgery is once you fix it, it's kind of you don't have to keep following it until like 5 or 10 years later. But it is hard. It is a big surgery. It's hard to recover from. And so now we do the endovascular repair, endovascular aneurysm repair. The problem with this is, we kind of try to push the limits of what we can do, because like I said, it's not, this is like, if this is like an aneurysm, like I would love if every patient had this kind of anatomy, right? Because we have to look at a couple things. We have to look at, one is where the aneurysm starts in relation to your kidney arteries, because if it starts up here, then you're relying on this segment right here. It's called a seal. So usually we want about 15 millimeters or 1.5 centimeters of seal sew. So the blood comes here, and then it comes down to here, right? It's like a graft, essentially. But if you don't have that seal zone and it goes all the way up to here, then we start saying you either have to get open surgery, or we got to look at different devices and different techniques to address that. Because the problem is, if you don't have a good seal, you can develop what's called a leak. And so essentially, what that means is, as time progresses, the blood flow can go in between this graft right here. And then if you see you can see like some arteries coming off in the aneurysm. Blood flow can come kind of through this artery and then back into this area right here. So you can develop leaks. And so that's why when we do these EVARs, it's great. We do the surgery, you stay overnight, we discharge you the next day, but it's something that we got to follow you up. It's like every 1 month, 6 months, and then every year after, to make sure that you're not starting to grow again because you developed a leak somewhere. But this is like this is kind of like a picture over here. You can see the aneurysm. This is the blood flowing. It kind of pooches out right here. And then after that, when you do the repair, the blood flow goes through here and through the graft down here, and then it splits off into your left and right leg. And then after that, and it's essentially fixed. Again, it requires a lot of surveillance afterwards, though. So it's not like a one and done, I'll see you later. We're friends for life now, okay? So, coming soon, as you're asking, it's like from my standpoint, I'm very adamant about, just capturing patients, like getting screening, making sure, because unfortunately, vascular surgery specifically is like kind of like the redheaded stepchild of all of medicine, right? Nobody knows a lot about it. We're kind of like the nerds sitting in the back, like on our own. So nobody knows a lot about vascular surgery. Nobody sees, like, a lot of people don't see the warning signs, or like, they don't even know, like, that there is a concern for certain symptoms or things that exist. And so it's like, sometimes patients will come in and, if they have like even Dr. Becker said in his lecture, like someone comes in and like they have a toe wound or something, it's like we treat the toe wound and then we wash our hands and walk away. But it's like that toe wound is a symbol, or like it's a big indicator that there are other things that are have massively gone wrong in the body that we need to address. And so, unfortunately in this day and age with, with healthcare, we kind of treat what's there at that time and then kind of move on. And, for me, I think that we're missing a huge part of, caring for patients when we do that. So we've been kind of spearheading this thing where we can kind of offer screening to the community, not for like those, those third parties where they're like, oh, we'll charge you like $100, $200, so to screen for PAD, because like I said, a lot of people are asymptomatic. You don't even know you have issues, and then suddenly you get these ABIs and you're like at 0.5. It's like, oh my God, like where, like I didn't even know I had this problem. And then like, at that point, if we can capture you at that point and start with our risk factor modification, start watching you, making sure we're aware of all the symptoms and all the things, then I think that we could do better moving forward. And so we're just kind of spearheading. We're trying to get the equipment, trying to get the money and like the equipment to make sure that we can do this properly, so that we'll screen for a PAD by doing like the ABIs, look at your ultrasounds to look at the carotids, and then look at the aneurysms, look for aneurysms. So that's coming soon. So I think, a little plug for LECOM, but if they're interested, I think once we start doing that, we'll probably start trying to advertise as much as we can so that everyone has access to this fairly frequently. That way we can really do something good for our community. And then our last thing is venous insufficiency. I think everyone and their uncle. Yep.
When you say coming soon,
Yeah.
it refers to the local hospitals or in general?
Well, mainly with LECOM. We're gonna try to get this started. We'll have a place, and then we just have to pick a place and time and really advertise it, and make sure it's available for everyone. And depending on how what the turnout is, it'll kind of determine how often we'll do it. But we have to get all the equipment and get everything ready. Make sure we have the staff to get that going. But we're almost there. Just keep an eye on the billboards. Any other questions? No? All right. So the last one is venous insufficiency. This is an exceptionally common problem that I think, many people have. So venous insufficiency, mainly symptoms, so it's problems with your veins. So main symptoms are like swelling the legs, especially if you've been standing for a long time. Varicose veins, everybody knows what a varicose vein is, just like those large ropey veins, or small little spider veins, something like that. Pain or heaviness in the legs. And then as time progresses, when you have persistent swelling, persistent pain, persistent swelling, ultimately all that fluid that kind of builds up in the legs will lead to a lot of skin changes. And so it's like it's itchy, it's dry. You go from like super swollen, then after that your skin comes down, and then now it's like you got super dry and dry, scratchy skin, flaky skin, and then after that you go through another process where it gets swells again, and that constant swelling to normal, swelling to normal, swelling to normal, that really alters how your skin kind of repairs itself. So ultimately, with that, the skin starts getting smaller and smaller, more scarred, and more just abnormal. So it's like it's harder. The skin is harder. It's more scarred, and it's more difficult to heal. So unfortunately, after that, the next step from that is then people start developing sores. Okay, usually these sores are on the insides or on the inside of the leg near the ankles. Sometimes it's right on the shin. So the main risk factors, the biggest one is valve dysfunction. So if you look, you have valves in your veins, right? So when you're standing, your blood has to go from your feet up to your heart. So it's got to fight against gravity. So if you didn't have these valves, they're just gonna, the blood, it's just gonna pool. So we were blessed with these little valves that the blood goes up, and then the valves close, and then it just kind of like a chunk, yeah, exactly, and goes straight up, right? But if someone doesn't have good valves, then the blood goes up, and then the blood comes right back down, and it goes up, and then comes right back down. So we call it reflux, okay? So this is like one of the major risk factors for, for developing venous insufficiency. You can also get venous insufficiency, so that's usually through your superficial veins. You can also get venous insufficiency if you have a history of blood clots. So when patients develop blood clots, these valves, if this gets clotted off, these valves, they get kind of, the history of blood clots is you have a clot there, so it's plugged up. Then as the clot slowly dissolves and gets, eaten away, it scars these veins, these valves, and so they're just kind of plastered up against the side of your walls. So at that point, they don't even work anymore. They're just stuck. And then unfortunately, age, that's something we can't stop. Pregnancy, for either with the increase, it has increased pressure, but also the hormonal changes. And then unfortunately genetics. So it's like, usually people are like, my mom gave me these veins. It's true, she did. So the treatment is always the same. It's always compression. So compression stockings, usually 20 to 30 millimeters of mercury. Leg elevation. So when you're not on your feet, if you're sitting down, prop those legs up. Ideally, they say like you should put your legs above your heart, but no one wants to stay in that position. So as long as it's up and not dangling in a dependent position, that's usually what we ask for. Exercise. Exercise is a big one because for two things. Obesity, like we said, is a huge risk factor. So exercising, losing weight, and all of that, weight loss, that significantly helps the amount of pressure that you're putting on your veins. But also, when you exercise, your veins, by just moving all your calf muscles, I like to say, are like the heart of your veins, right? Because every time you move your calves squeeze your veins to shoot that blood up. And so by doing that, you're going to drain your veins a little bit more efficiently with constant exercise. And so exercise is exceptionally important as well. If for any reason that doesn't work, then we talk about radiofrequency ablation. So this is only for the superficial veins. So you have two sets of veins. You have a vein that runs on the inside of your leg, that's superficial, and then one that runs behind your knee down to your ankle. So those are it's called the saphenous vein. So those veins are the ones that are usually the culprit for having faulty valves that give you lots of pressure, that can cause the ulcers, etc. So if the stockings don't work, then we start talking about radiofrequency ablation. So essentially we advance the catheter up, and then after that we just hit a button essentially, and it emits all this energy, and it kind of essentially like just burns this vein all the way down, and it gets rid of that source. And then after that, if there's a lot of varicose veins, we essentially do what's called stab avulsions, where we use a little 11 blade, and we make little nicks over this is a cute little one. Usually the varicose veins are really large, but we make a cute little incision here, and then we scoop this vein up, and we exteriorize it, and then we either like tie it off or essentially rip it out so that it's no longer in connection with each other. So once you disrupt this network, that large varicose vein essentially will go away, or some of it's taken out, but whatever's left over will no longer be there and no longer be an issue. So that's like the main treatment for superficial venous disease. Nowadays, the DVT world is huge. Before, we didn't treat DVTs that much because it's super high risk, right? It's usually their leg has to be threatened before we even treat the DVTs. But now they're coming out with all these new different devices to clean out all that clot, but also for patients who've had DVTs like 1 or 2 years ago, and have this venous insufficiency. Now there's more devices to help, reopen this vein, clean out that vein, or like restent it to help with the venous insufficiency. But that's still ongoing. There's like no great study or anything like that, because all these devices are pretty much like released in the last couple months. So, but that's kind of coming soon as well. And that, for a lot of people who've had the history of DVT and are having all these big wounds because of that, could definitely benefit from these procedures as well. That's all I got about veins. Yep.
They used to inject saline into the veins. They don't do that anymore.
Usually it's like sclerotherapy, it's like SDS. It's like, tetradecyl or something like that. It's like almost like a soapy acid that kind of burns the entire veins. You could still do that for spider veins. The very small ones, you can inject them and it kind of burns away that vein away.
And do they do those vein ligation and strippings anymore?
Stripping, nobody does stripping anymore. Yeah,
Those are brutal.
it's pretty brutal. Yeah, so nobody, and I wasn't even trained on how to do it because it was just like, we just don't do that anymore. Yeah.
Thank goodness.
Any other questions?
Oh, we got one over here.
Are you at the end of your talk? Or?
Yeah, I'm done.
Okay. Well, so one thing that occurs to me, that when you get older and you hear all that, there's really no indication that you have that. You could be going along and not knowing anything about all this stuff.
That is true.
I mean, that's a good thing, is it, or not?
I mean, some say ignorance is bliss until something happens. But I mean, for the most part, like I said, these are for patients that are very high risk. You're looking at patients who've been smoking all their lives, that been smoking since they're 12 or 13, who, have bad diabetes, bad uncontrolled diabetes, horrible blood pressure, horrible cholesterol. Like, these are all just, unfortunately, like I said, well, there's no one size fits all. And so, like, we have to look at the whole history of a patient. Like, if there's someone who's like never smoked in their life, like might have some blood pressure issues, but not that bad, is only on one medication, am I that worried? No, not terribly, but it all depends on where you are on this gamut of risk, essentially.
Okay, another question I had, is there anything coming about medications that remove plaque, actually? They dissolve it and just get rid of it?
So, yes and no. I'm going to say no, but I know that there is something, like there's a lot of like herbal medications, or all these like GNC type things that that are coming out, like, oh, we can do this and that. I don't know that there's a lot of good data behind a lot of it. I know that there's something that's soon to be coming out that that is mildly promising, but I haven't looked at the data yet. But so right now, I would say no. There isn't anything that with adequate data that shows like you can get rid of plaque and keep it away.
You were saying that people should take statins. Mm-hmm. What if you can't take statins?
Yeah, unfortunately, that is a problem. A lot of people are not tolerant. So there are other medications just to bring down your LDL. You don't get that added benefit of the stabilizing the plaque, but bringing down that cholesterol is, the best thing that you can do, regardless of what medication. Like there's like a ezetimibe, there's like the injectables now that they have. That's pretty much it.
If there's no more questions, we can give Carleen a round of applause.
All right,
Thank you so much for coming.